Hey everybody, for those of you that don't know me, my name is Balal. I'm one of the PGY1s, and today I'm gonna try to go over the EKG and STEMI. So just an outline, today I'm gonna go over the features that are suggestive of ischemia, reciprocal changes, and then we'll do some practice EKGs. Okay, so in general, whenever we have a patient with chest pain or any features suggestive of ischemia, we should try to get the first EKG within like 10 minutes if possible. I know that can be tough sometimes, but try to push for it. It's probably the single best test to identify a patient with an acute MI upon presentation. A lot of times we're also going to have patients who are high risk, like our diabetics with hypertension and ischemic heart disease who have persistent symptoms throughout their ED stay. We should try and get a repeat EKG on those patients at some point during their time in the ED. We should also remember that even though it's a great test, we can have false positives. And there are going to be instances where we have a patient with a normal EKG and they may still be having an MI. So I feel like a lot of us have heard about looking for inverted T waves. So I just wanted to go over why T waves are normally in the direction that they're in. So T waves represent ventricular repolarization, and they're normally asymmetric. They're upright in all leads except AVR and V1, and we can have an isolated normal variant, which is inverted T waves in lead 3. And I was just curious why it occurs in the same direction as the QRS, despite the fact that they are electrically opposite events. So the QRS complex represents depolarization of the ventricles, and depolarization starts where the Purkinje fibers are, near the endocardium, and it proceeds towards the epicardium, which is where the surface electrode is going to be. So this is a positive vector moving towards the surface electrode on our skin, which is going to register as a positive deflection. Now, repolarization is an electrically negative event, but for some reason it occurs in the same direction as the QRS. Now, the reason for this is that during systole, there's increased stress on the endocardium, so the repolarization is not able to occur in the same direction. It occurs in the opposite direction. So we have repolarization moving from the epicardium towards the endocardium, which is going to be a negative event moving away from our surface electrode, which is going to register as a positive deflection. Now that we know what's normal, we can be on the lookout for inverted T waves and hyperacute T waves. Now, the reason we have inverted T waves is when we have subepicardial or transmural ischemia throughout all the layers of the heart, it causes a repolarization abnormality, which is going to lead to it going in the opposite direction and us having an inverted T wave. We can also have hyperacute T waves, and these are just going to be the T waves on the EKG to the left. These can be seen with subendocardial ischemia, or when you have a patient presenting very early on with an acute MI. And it's important to look out for any changes in T waves like inversion or hyperacute T waves or symmetrical T waves, because oftentimes these are the earliest subtle changes that occur in a patient who's having an MI. And if you gloss over it and you don't do a proper workup and get a repeat EKG, you can miss a STEMI. So according to the 4th universal definition of an MI, there are specific criteria for our ST segments to meet, like ST elevation criteria. And those are going to be 1 millimeter of ST elevation in any 2 contiguous leads, except V2 and V3. For V2 and V3, the level of elevation is going to depend on your age and your gender. In women, the cutoff is 1.5 millimeters at any age. In men, it's going to be 2.5 millimeters under 40, and over 40, it's going to be 2 millimeters. Now, it's important to remember that these cannot be applied to left bundle branch block or left ventricular hypertrophy, and that they're only suggestive of acute MI. They're not the end-all be-all. There are other EKG patterns that are suggestive of an acute MI that do not meet this definition. Dr. Silverberg always says that residents miss Q waves. So what to look out for in a Q wave is, for a pathologic Q wave, is that they need to be wider than 0.03 seconds, and they need to be greater than 1/3 the height of the QRS complex. You can usually just eyeball this. Some people use like calipers, but personally, I think eyeballing should be fine. They're important because Q-wave infarcts are associated with higher incidences of acute mortality, increased tissue damage, as well as the development of CHF. EKG changes can occur predictably by like region, depending on which territory is infarcted. So if you see changes in 2, 3, and AVF, it's in the inferior region of the heart. 1, AVL, V5, and V6 is lateral, and V1 to V4 is going to be septal and anterior. Reciprocal changes are something that are still a little confusing to me, but I wanted to try and break it down the way that I was able to understand it. So a reciprocal change is basically a mirror image that refers to 2 electrodes viewing the same area of ischemia from about 180 degrees apart. So if we look at electrode A, initially we have a vector moving away from it, which is causing that negative deflection or the Q wave. That same vector is going to register as a positive R wave in electrode B. And there are going to be other vectors which cause the upstroke of the QRS in electrode A, which are going to register as the downslope of the R wave in electrode B. And just like that, we have ST elevation in electrode A because of repolarization abnormalities. That's going to end up registering as depression in electrode B, or a reciprocal change or mirror image in the other lead. If we look at the lead placement by the diagram of the heart, in lead AVL and lead 3 as well as lead AVF are as close to 180 degrees apart as you're going to get. So if you have changes in 1 and AVL, you should look at 2, 3, and AVF for reciprocal changes, just because based off of where they are placed, that they're about 180 degrees apart. I think it's also important to note that on the standard 12-lead EKG, V1 to V4 do not have any leads that are reciprocal to them. You're going to need to get posterior leads to find reciprocal changes for those leads. Sometimes we might mistakenly say that there are inferior depressions in an anterior MI. The reason that you have those depressions is because there's lateral involvement. So again, just to quickly sum up, if you have changes in the inferior leads, look at the lateral leads. If you have changes in the anterior leads, look at the posterior leads and think about getting a posterior EKG. So the important signs of ischemia are going to be our changes in T waves, whether that's inversion, hyperacute, or symmetrical T waves, ST segment changes, whether it's elevation or depression, reciprocal changes, and pathologic Q waves. All right, so now let's go over some practice ones. Does anyone want to tell me what they see? Or like anything big that they can notice right off the bat? Anybody?
The elevation of V1 to
Yeah, exactly. So we have deep symmetrical T waves as well as ST inversions, just like Dr. Willis astutely said. And the other thing we should notice is that there's not many, there's no reciprocal changes. Just a good reminder that these leads don't give reciprocal changes. And the Q waves, which even after I said it, I missed it. So that's how important it is. We have Q waves starting to form in 2 and 3. I think if you have a patient with this EKG, D'Souza will let you order a troponin. I haven't asked him, but probably.
Well, you could argue you don't need it.
So here we have obvious elevations in 1, AVL, V2, V3, V4, 5, and 6. We've got Q waves starting to form. And just important to look out for these reciprocal changes. We see these depressions in 3 and AVF and AVL and 2. And I think it's also good to notice that the T waves are pretty hyperacute. And if you have a patient like this, it's a good idea to probably be like pretty aggressive because they're very early in their presentation and they have the most salvageable myocardium. Anyone want to do this one? Camille, Rabani?
I see some ST elevations in 3 ABS, depressions in 1 ABL, maybe some elevation in 2 as well.
Yeah, awesome. And I think this is just a great example that you can look for reciprocal changes for the inferior leads in the lateral leads. This is another inferior STEMI, but there's something else super important here that we can notice if anyone wants to take a crack at it. So what we have in this one is we have an inferior STEMI and we have elevations in B1 and elevations in B2. We also have ST elevation in 3, which is greater than the ST elevation in 2. These are important things to look out for because these can be signs of a right ventricular infarction. So if you have someone with like signs suggestive of a right ventricular infarction, you should get a right-sided EKG. And if you get a right-sided EKG, you only need one lead of V4, V5, or V6 right to have elevation in order to diagnose a right ventricular infarction. And these are important just because these patients are super preload sensitive and they can develop severe hypotension in response to nitrates. And we should probably give these patients a fluid bolus. And again, just to look out for, things to look out for are elevations in B1 and B2 and ST elevation in 2 and 3, which is greater than 2. We have an inferolateral STEMI here, and one other important thing, if anyone can notice it. So we have depressions in B1, B2, and B3. And earlier we talked about how lateral and inferior are reciprocal and anterior and posterior are reciprocal. So if we have a patient with a STEMI who has depressions in B1 to B3, or these like tall, broad R waves in V2 and V3, they should clue us into that the patient may have posterior extension of their MI. I think it's super important to notice the R waves because if you're having an anterior MI, the patient is going to have decreased R wave amplitude and poor R wave progression, as opposed to these like broad, tall R waves. So in a patient like this, you should get a posterior EKG. And this is the same patient who had a posterior EKG done and it showed elevation in V7, 8, and 9. And a lot of times I think we might have to be the ones instructing the techs on how to do this. And it's pretty simple. V7 goes in the posterior axillary line. V8 is going to line up with the tip of the scapula, and V9 is going to be placed paraspinal. So just to sum up, obtain the EKG as soon as possible when there's a concern for ischemia. In addition to evaluating your rate, rhythm, and intervals, look at the T waves, ST segments, and Q waves, and look for reciprocal changes. And don't be lazy and get a right-sided and posterior EKG if you need it. And references. Okay.